I'm Niall Paterson. Welcome back to the Sky News Daily, where, no doubt like you, we are still getting our heads around the news that the King has cancer. And I would direct you to yesterday's episode if you want the lowdown on what the palace has said about Charles' diagnosis. In short, it was discovered during the prostate procedure that we were told of days ago. It is not prostate cancer, though we don't yet know what type or indeed stage it is, and his treatment has already begun. But let's be brutally honest here. King Charles, by merit of his position, his birth in fact, has an ability to access healthcare that most do not. On top of that, a life of privilege and regular medical checkups place him at an advantage when it comes to most health outcomes, not just cancer. So today we are focusing much less on Charles himself, but on the current state of oncology, of cancer care, that the majority of us can expect to receive. A little later, I will be speaking to the president of the Royal College of Radiologists, who herself works with children with cancer. But we begin with Tom Cheshire, our data and forensics correspondent. Tom, look, we are explicitly not looking at King Charles, his treatment, his prognosis, but we can talk in some generalities, I think. Why don't we start with perhaps the most obvious point, that a diagnosis of cancer in the UK, in this day and age, it's not uncommon.
1 in 2 of us will have some form of cancer over the course of our lives. And we see more and more people diagnosed with cancer as we're living longer. We now see 1,000 people diagnosed every day.
For all my chat that we're not going to focus on Charles, let's just briefly talk about, those who are in that age group, that demographic, men 75 plus. Now, we know from the palace that it isn't prostate cancer, but actually you look at the data, and in terms of the age bracket that the King falls into, prostate cancer is right at the top of the list.
Yeah, if you're going to get one cancer as a man, it's most likely to be prostate cancer, especially when it comes to men aged 75 plus. After that, though, you've got lung cancer, bowel cancer, colon, bladder, rectal cancer. Younger men tend to be melanoma, things like that. Leukemia for children is one of the most common types down there. So prostate is the most common type, but as you said, that's the one we know that it isn't.
Where are we in terms of, I would suggest, the most important metric when it comes to cancer? Survival rates in the UK.
We're talking about those diseases specifically. Again, you can break it down, Rich. So lung cancer, sadly, only 1 in 10 people, if they're 75 plus, will live 5 years after that. For other ones like bladder cancer, it's 4 out of 10 after 5 years, so those are better. And we have been getting better at it. That said, we're not great. If you compare it to other countries, OECD countries, so other rich, developed nations, we lag behind in all sorts of things. Now, caveat to this is when you're comparing some of this data, this is quite old, and actually this only goes up to 2014, but I think it's fair to say that things haven't got better since 2014, really, especially if you look at some of the other things, which are definitely worth talking about in terms of waiting times, referral times, diagnostic, and we'll chat about that. But when it comes to things like colon cancer, our survival rate's way beyond a 5-year survival rate, way worse than our peers in developed countries. Breast cancer, we screen actually really well for breast cancer, up till 2014 at least, that's the latest data. But our survival rates, again, we are behind our peer countries like France, we're way behind Australia.
Let's deal with what, again, I suppose are the two biggies when it comes to working out why we are not doing quite so well when it comes to survival rates. And that will be diagnostics, discovering what someone has, and then the treatment that would follow. Tell me a little bit about both.
The number of people getting referred for cancer it's gone up hugely. We're talking about earlier, right at the start, that 1 in 2 of us will get it. The number of people being referred for cancer has tripled since 2010.
Wow.
So there is a huge amount that the service is having to deal with.
And some of that presumably will be people being more aware of their own health and therefore going to the doctors.
It's not to say sort of health has deteriorated massively. It's because people are getting referred earlier. There's a lot more education around it. The problem is, so you have all those people coming in to do it, but then what happens when you get there? When it comes to diagnostic tests, so this is just diagnostic tests across the NHS, it's not specifically for cancer. That's just got way worse since 2010 in terms of the number of weeks it takes to go and get that test. So you think if you're going in for a colonoscopy, perhaps, that is now 3.4 weeks for colonoscopy in November compared to November 2019. Now, we've had the pandemic, but what we've seen is the big bump in all those figures. Then they level out, they've come back down, but the demand is way higher. And you think, well, that's an extra week and a half. And that's really important because when you catch a cancer, really determines survival rates.
It's the mantra we always hear. Go see your doctor. If you've got a problem, go see your doctor straight away. If you catch it early enough, the chances of success dramatically improved.
So take lung cancer. This is just across the board. This isn't for 75-year-old men. But if you catch it stage 1 cancer, 62.5% of people, they'll live for 5 years at least. If you catch it at stage 4, it's just 7.4%. So that is really, really crucial. And again, that comes back to, well, if you have these waiting lists, which are very long, if you have these diagnostic tests that are taking ages, does that mean you're more likely to go from one stage to another? Your chances of survival drop. Is that why, compared to our peers in OECD countries, we're not doing as well? We were hearing from the PM that this was caught early for Charles, so that that bodes well in terms of that specific diagnosis, even if we want to sort of extrapolate that out.
I suppose this kind of brings us back to where we started. And of course, the thing we don't know is what type of cancer the king has. For whatever reason, they've chosen to say that it is not prostate cancer, but not go any further. He had his cancer diagnosis because he was in hospital for an unrelated procedure. How many people are that lucky when it comes to a situation like this?
He was in a private hospital for something else. He started his treatment. More than 1 in 3 people referred for cancer treatment are waiting more than 2 months to begin treatment. So that's not an immediate thing to start with. The clue is in the name. The king is getting the best possible medical care, and is a very uneven picture across the country, especially when you talk about deprivation. So if you look at areas which are more deprived versus less deprived, you look at the top sort of 20% versus the bottom 20%. The survival rates for all sorts of cancers are much higher if you're richer. And some of that may be because of private provision, but it may also be because actually it's very geographic. You get some trusts in more deprived areas which really struggle, which have low rates. There are some exceptions to that rule, but as a general rule of thumb, you can map this by postcode. So when it comes to things like prostate cancer, for example, you're more likely to survive that if you're richer. But other things like lung cancer, 28% of people have a 4-year survival rate for that when you're from the rich area, compared to just 21% if you're from a poor area. So there's massive sort of inequalities in health related to income in this country.
Why might that be? Having several £100,000 in your bank account per se does not improve your health.
I think screening is probably one of the big things in terms of awareness. A lot of people doing annual checkups, having the time to do that, having perhaps insurance from their company or private insurance to go and do that, because that feeds back to what we're talking about, the stages of cancer when you get there. And then there is that other massive health inequality, which is being in the UK versus other countries. If you're in Australia, in America, you are more likely to survive. So, this is definitely a UK problem, but then within the UK problem, in terms of income, in terms of geography, there's all sorts of differences.
A constant mantra in our conversation today, Tom, has been that compared to others, we are not doing that well. But even when we just judge the health service, this government, on their own targets, they've consistently missed them, haven't they?
Let's put it in context. The pandemic did have a huge effect on that. A lot of pent-up demand. You see those spikes. When it comes to those targets, they do exist for a reason, and we just haven't been meeting them at all. 4 weeks from referral to diagnosis, we don't meet that target. 2 months from referral to treatment, again, for cancer, we don't meet that target. We're a long way off meeting that target. We're sort of 65% of people when it should be closer to 80%. The government set out to try and meet those targets. We had a big thing from the Prime Minister, Rishi Sunak, admitting that they hadn't been hitting those targets, but not really saying, well, what are we going to do about it? This is going to be a long-term problem. We've got a hugely aging population. People living longer are going to get more complicated diseases. It's going to put more strain on the health service. And it's not moving in the right direction, at least as it stands right now.
All of which I would suggest would lead plenty of people to believe, look, if you have cancer and you have the money and you have the opportunity to go off and get that immediate care that private healthcare provides. But we should probably be absolutely clear about this. King Charles was born, raised and lives in castles and palaces. He will have had almost constant medical screening as part of his role as heir to the throne and now as monarch. He will have eaten the best food. He will have had dietitians. He will have had advice about nutrition, again, all the way through his life. King Charles, his cancer and his treatment is not a representative sample of what it is like to be a cancer patient in this country.
100%. Just the fact that he is already receiving treatment, he hasn't had to wait for that diagnosis. As you say, the fact that he is a relatively healthy 75-year-old, a lot of people get to 75 and they're not in the shape that he's been in. But he's been very active. He was obviously in hospital for that other operation, but otherwise, pretty healthy. And then he's got the best people looking after him. That is not the case for everyone else. And it can be very, very tough to get a diagnosis, to get a test, then to get a referral, then waiting on that. and the sense that it is not getting better. So yeah, he is a complete one-off in terms of the average cancer experience of this country. In a very privileged position, we want him to be healthy and well and wishing him all the best, but that is not the average experience for someone with cancer in this country, because it is not as good as that.
Tom, many thanks. In just a moment, we'll return with the President of the Royal College of Radiologists. So, thus far we have had a snapshot of cancer care here in the UK through the data, of which there is plenty. But what of the experiences of those providing that care? Dr Katharine Halliday is the President of the Royal College of Radiologists. She works with children with cancer. Dr Halliday, thank you so much for being with us. Tell me about the day job. I mean, of all aspects of working within the health service, having to see children, incredibly sick children suffering with cancer, I am sure there are rewarding aspects to the job, but it must be a grind as well.
So my job, I'm a diagnostic radiologist, so I specialise in imaging of children. But many parents are worried that their children might have cancer when they come. So an important part of my job is reassuring people and making people feel more relaxed. So I spend a lot of my time looking at images, so either X-rays that have been taken of children, or MRI scans or CT scans, or sometimes ultrasound scans where I actually scan the patient myself. So I'm sitting next to a child who's lying on the bed and their parents are there. And quite a lot of my job there is trying to reassure the child so they're not frightened, and also sometimes just persuade them to get onto the couch and have the test in the first place.
From your perspective, both as President of the Royal College of Radiologists, but also as someone who runs a radiology department, how well are we doing at the moment in your very specific area of dealing with cancer? The data does show that there are weights, key points in the pathway to treatment, including the treatment itself, that could be resulting in negative outcomes for cancer patients in this country. What's your experience?
Overall, worldwide, we're doing much better at cancer survival rates over the last decades, really. In the 1970s, only about 25% of people who had cancer survived for 10 years. But now, about 50% of people with cancer will survive for 10 years afterwards. So it's not the death sentence that it was, but that rate of improvement has slowed in the last decade. In terms of what's happening in diagnostics, if you think you might have cancer, or if you go to your GP with a symptom and your GP thinks you've got cancer, then they might refer you for a test. They usually do refer you for some sort of test, often an imaging test, which is what I deal with, so an X-ray or a scan. And the waits for those are increasingly long. So that's the first stage, that a patient needs to have the scan. If the GP thinks it might be cancer, they may refer you on a special pathway that means that you have your scan within 2 weeks. But a lot of other people have non-specific symptoms, or in fact, about 18% of people present it as an emergency to the emergency department with their cancer. So they may have had symptoms which they haven't taken much notice of, or they may have had very minimal symptoms. And so they present by a different route to the emergency room. Other people present via screening programs, and we are very much trying to increase the number of people who take up screening in the UK, so as we detect the cancer at an early stage, because the earlier you detect it, the more likely it is that the treatment's going to be successful. So once you've had your scan, then that needs to be reported. So it needs to be reviewed by a radiologist, somebody like me, to have a look and make the diagnosis, feed that back to the doctor who will start the treatment. And the waits for that part, the reporting, are getting longer because there aren't enough radiologists.
I mean, that was going to be my point. I mean, there are these gaps in the system. There are waiting times. Is this entirely due to, the staffing crisis that we know that exists across the health service, or is it linked to the fact that there are a finite number of scans in a day that can be performed on a piece of equipment? Which of the two is the problem there?
We could always do with more equipment, and there could be more equipment in better places for patients to access. Sometimes it's very difficult to get into the nearest hospital, for instance. But the biggest problem is actually staffing, because you need staff to run the scanners all the time, and then you need people like me, radiologists, to report the scans. And actually, the number of people who are getting scanned goes up by about between 7 and 10% every year, and the number of staff isn't keeping up with that. And so people are having to wait longer, which is very stressful for them, whatever the outcome.
How is it for you? I suspect frustrating.
It is frustrating, yes. I mean, everybody who works in the health service wants to give a good service to their patient. And when you can't, it is quite stressful. It's quite stressful for staff. And I think that is having a very negative effect on some staff and can actually, in turn, affect retention of staff, because some people think, well, I just find this too much, I'm going to retire early or something like that.
So there are, and obviously I'm not asking you to name names, Doctor, but there have been colleagues of yours who have been frustrated, upset at the delays, that they can't provide the level of care, with the level of care, or the care as speedily as is necessary, who have chosen to leave the profession rather than carry on.
Yes, I mean, particularly older people who are getting near retirement. We're noticing the data that we're collecting suggesting that the retirement age is getting younger. So I think last year, 75% of both oncologists and radiologists who retired were under the age of 60, which didn't used to be the case. People used to stay on until after 60.
And all that experience as well is being taken out of the system.
And also the ability to teach younger colleagues, because the experience is not only useful for actually turning over the work, but it's also useful to hand on to younger people. So that's something we're trying very hard to address.
Tell me then a little bit about what you think. And of course, we know none of the specifics of King Charles' diagnosis beyond the fact that it is not prostate cancer. I'm almost less interested in what your thoughts are as to his treatment. More your thoughts as to what someone as public-facing as King Charles, going public, first with the issues surrounding his prostate, and then secondly with this diagnosis, what you think that might do for cancer awareness in the kind of in the public at large.
Well, the first thing to say is I'm so sorry about King Charles's diagnosis. It's very difficult for him, and particularly difficult since he has to go through it in this very public-facing role. But I think it's very courageous to come out and talk about these things, because it makes it much easier for other people to come forward with their problems, and indicates and shows people that the thing to do is to accept it, embrace treatment, and move forward.
Dr. Halliday, just to go back to where we first started and the job that you do, how do you do what you do day in, day out, with some very, very sick wee people sitting in front of you? I mean, do the good days genuinely outnumber the bad?
Yes, working with patients is always a joy. I often have great fun with the children that I'm scanning, and they're very curious. With children who are more seriously ill, you can do everything you can to make it the best possible experience. There's a lot to do for children, because you can make a big effort to make them feel relaxed, making a child-friendly environment, explaining things to them carefully, reassuring their parents. I'm continually impressed by people's ability to make sacrifices for their children and the love they show for their children in those difficult times. And it's an absolute privilege to be part of that process, actually.
No thoughts of early retirement just then, I'm hoping.
Not for me.
Dr. Katharine Halliday, you keep doing what you're doing. Thank you so much for your time. And we, of course, send our very best to Dr. Halliday and the rest of our colleagues in the NHS tackling this most horrific of illnesses. Indeed, there's no need for me to labour the point that cancer can be desperately cruel. There can't be a single person listening to this podcast whose life has not been touched by it in some way or another. After all, 1 in 2 of us will develop cancer in our lifetimes. But 1 in 2 of us will not receive the care that Charles does. Far from it. That's your lot for this edition of The Daily. We'll see you again next time.